Hi everyone, welcome to Ask the Egg Whisperer. I'm super happy to be here today to answer your questions. The first question I'm going to get to is from Vicky, and Vicky asked how much caffeine is okay for 3 months before IVF, during stim, or after an embryo transfer. So let's break it down for Vicky. And for those of you who are listening and watching, remember that this is education and information and not medical advice. I'm just sharing with you guys what I would do if you were a patient of mine asking me these questions, but always ask your doctor these questions as well. So Vicky, here's what I would say 3 months before IVF. Drinking coffee is not going to hurt your fertility. It just won't. However, you know that saying, everything in moderation. When it comes to during stim, I actually ask my patients to consider drinking coffee, especially because guess what? The stim meds can make you feel super sleepy when that estrogen fog rolls in. They can also make you constipated, and a little bit of caffeine can certainly help with the problems of constipation. After an embryo transfer, same thing. Those meds just make you feel so sleepy, and sometimes you need a little bit of a pick-me-up. However, once you're pregnant, coffee can make your heart race. It might make you have a hard time sleeping, causing you to have insomnia, and that can be super irritating. So be careful. If you're someone who feels a little anxious, maybe reduce the amount of caffeine, but 1 to 2 cups per day didn't drive an embryo away. So Vicky, you can have your coffee if you're a patient of mine, of course. This next question is from Greta. Greta says, I recently had my first IVF transfer. It was a 5BB from a frozen egg donor. It was successful, but my doctor unfortunately had me stop medications and I had to pass the pregnancy because the HCG was not doubling as expected. From this cohort of 8 eggs, I had 2 successful blastocysts, but the embryo that's left is a 6AC. The embryologist advised that the embryo is not good, but it's transferable. Do you recommend using this embryo or purchasing a new cohort? Greta, here's the deal. What do you want? What is it going to take, and are you willing to do it? I don't know how many kids you have at home, but if you really want at least 2 children from the same cohort, meaning the same egg source or egg donor, if you were a patient of mine, I would encourage you to make more embryos. The amount of time that it would take to prepare you for a transfer and then find out it didn't work, now we're looking at so much time that's passing. So, Greta, I would say if you're open to another cohort of eggs, yes. And for those of you guys who are like, what is a cohort? What is she talking about? What she's talking about are eggs from an egg bank. So when we look at egg banks, I have about 5 that I work with. I have patients find a good match for them, and then I go to the egg bank director and I ask them the questions that I would want to know if it were me as a patient. Fertilization rate, blast formation rate, live birth rate for this cohort. And then I tell my patient what the previous success was for this cohort and what we could potentially expect, of course, if that donor had been used before. So in this scenario, it sounds like these are still high pregnancy potential eggs because you got 2 blasts, even though one was really much better than the other. So the other thing that we would talk about is whether we should consider a different set of eggs for this next thaw. I would also have you think about sperm. Don't forget about the sperm. Make sure it's sparkling on the day of the thaw. I have a certain checks and balances little box that I check on my order for the IVF lab. It's like going in for, when you go into the omelet bar and you just tell the chef, well, I want this, I want that, I want that. Well, this is my version of a omelet bar at a breakfast buffet on a Sunday morning. The Church of Dr. Aimee. I'm just kidding, but not. So when I go to the embryologist, I always say, please do not thaw the eggs until you have the sperm and you know it's good and it's sparkling. Otherwise, do not thaw the eggs. I don't want a omelet made unless we have good sperm. Anyways, I know what you've gone through is not funny, and I'm just trying to make light of it. So please don't think that I don't think what you've gone through is very serious, but I hope my advice will help you. This next question is from Apotheosis. Apotheosis says, hello, I saw your video on YouTube, and I was intrigued by the information regarding men's fertility. I was wondering if there's a difference with men having, are you guys ready for this? This is like legit a question, and this is serious stuff. And this is actually something that I think you guys should know. Is there a difference between men having big balls versus small balls regarding their fertility count? My balls are kiwi lemon or cutie orange sizes, I suppose, for comparison. What is considered a normal testicle size, and should I be concerned about my balls not being normal size? Does fertility differ for different size balls? I assume that larger balls would be more sperm and higher sperm count. I have not had kids yet, but I always use condoms during sex. Should I be concerned with low fertility, or do I have nothing to worry about due to my size and my normal size? Any help would be appreciated. So apotheosis, I have to tell you that a kiwi, a lemon, or a cutie orange, those are big balls. So the best way now to find out if you have a normal sperm count, and I am saying this with a totally straight face, because this is what I talked about all day long. I'm used to saying this, is get your sperm count checked. That's the easiest thing to do. So you can use a test like Meet Fellow, MEET fellow.com/Egg Whisperer, and they'll send you a kit. You just do your thing, ship it back, and you'll get results. And if your sperm sparkles, like my sparkling ball eggs, earrings, they're not eggs, they're earrings, but they kind of look like eggs, then you're good. And if your sperm doesn't sparkle, well, then I would see a urologist and see what's going on. But the answer to your question is testicle size is definitely something that fertility doctors and urologists talk to patients about. And we also measure balls. I don't measure anyone's balls. I send my patients elsewhere to have their balls checked. And I'm doing this because I'm like, you can go somewhere else to have that engine checked. Look under the hood there. Okay, so this next question is from Sunny. Sunny is saying, hi again, beautiful Dr. Aimee. My name is Sunny. I'm 34 years old and I've been diagnosed with PCOS. I have hypothyroidism. I'm taking 88 micrograms of thyroxine. My AMH was 6.77, tested last October. The doctor said I was fertile but didn't suggest any other tests. I'm trying to conceive naturally. I have regular cycles every 32 to 34 days. My question is this. What test should I get done given that I have PCOS? Is there anything I can do to ensure that I ovulate? Thanks a ton. Okay, Sunny, here's the thing. So diagnosis before treatment, or I should say diagnosis before trying to conceive, just kind of figure everything out to create a roadmap for yourself. It is really helpful to know that you have PCOS, but the thing is why? Just having an elevated AMH level of 6.77 does not mean PCOS. It could also just mean you're a 34-year-old with a lot of eggs. It sounds like you're having regular cycles, so what else are we missing? The PCOS panel that I do on my patients includes testosterone, prolactin, sounds like you've already done a TSH, vitamin D, and a hemoglobin A1C. That's just a handful of the labs that I do. But I also feel like it would still make sense to consider a fallopian tube test, a sperm test, and genetic screening as well. So rather than just assume that this is PCOS, when I talk about PCOS, I remember the words, please confirm, not confuse, please confirm this ovary syndrome. But I feel like a lot of the times people are confusing it with an ovary syndrome that is not there. But it sounds like you're blessed with loads of eggs. So let's kind of understand what else is going on. And you can use the PROOV test, PROOV. They have a predict and confirm test that will allow you to track your LH surge and then confirm that you've ovulated by measuring a metabolite of progesterone called PDG in your urine. So see if that test is going to be useful for you and get your tushy checked. And for those who are watching me who have no idea what the tushy check is, you can simply go to tushymethod.com and those are the 5 tests that you can get done that kind of tell you more about your fertility. So this next question is from Lacey. And Lacey is saying, hi, I'm 27 years old with unexplained infertility. AMH is 2.3. I'm trying for 1.5 years. My question is this, when would you recommend a laparoscopy for me? For those of you who don't know what a laparoscopy is, that's where you take a camera, drop it down your belly button, fill up your tummy with carbon dioxide gas, and we just take a look around. If we see something we don't like, we remove it. Otherwise, we take lots of beautiful pictures to talk to the patient about what's happening. Here's the deal. I have some periods with very heavy flow and some clots. Some periods have bad cramping, but most of the time I can make it without Tylenol. I'm a bloater, and I just found out that I also have gluten sensitivity. My fertility doctor said we could do a laparoscopy before our first IUI, but seemed indifferent and said that with any surgery there's risk. I'm just wondering if and when would be the best time to investigate endometriosis. I also had a positive ANA in 2011 and just got results back that it's positive. I'm waiting to see the rheumatologist. So far, that's the only thing off. Okay, Lacey, so what you're describing is something that's really common. You're just doing some testing, but there's something big picture that still bugs you and you're just like, I wonder if that's it. So it is so good that you're listening to your ovaries and your uterus and they're telling you a story and you're like telling your doctor and it sounds like your doctor is being super helpful and you're just not sure what to do next. Here's my recommendation. There is a non-invasive test that does not involve surgery that you can do. Apparently the car's outside, if you heard that honking, agree. And it's basically done just like a pap smear, except it's a lot more painful. Speculum goes in, a small pipelle goes into the uterus. Your doctor will withdraw the pipelle. That's called an endometrial biopsy. Send the cells over to the pathologist that works for that company, and they'll basically tell you with a high degree of certainty if you have endometriosis or not, without a laparoscopy. So look into that test and see if your doctor feels comfortable doing that for you. And I'm not sure when you had your tushy checked, but one thing I sometimes do for my patients is track and trend their fertility levels, repeat the FSH estradiol, look at the sperm again, maybe look at sperm DNA fragmentation, make sure you've done enough genetic screening, look at a chromosome analysis in your carrier screen, and look at all those puzzle pieces, put a very nice fertility picture together, and then present it to your doctor and say very simply, what have we ruled out and what do you think I should do next? Because the thing is that depending on what you've ruled out, you can then talk through what the possible explanations are for your issues. So I don't like unexplained. I know you guys all know that. I always talk to patients about what the possible explanations are. So let's say we have a 27-year-old woman with loads of eggs, all the levels look good, including the sperm. You have to wonder, could it be silent endometriosis because of your symptoms? You have to wonder if there's a fertilization issue because of egg quality, or maybe something that's sperm driven that we just can't put our finger on. So IVF is one way to find out. That's a real life basically you're just going to get a diagnosis by going through all the stages of IVF, looking at the eggs, fertilizing them, watching the embryos grow. And sometimes you learn more about what's going on. At the same time, you're getting to your goal, because IVF can also be a successful way of helping you get pregnant. And last thing about your ANA, Lacey. So ANA is a very what's the word I'm trying to use? It's not a very sensitive test. So a lot of people are positive for ANA, at least 15%. So even if you're positive, it doesn't necessarily mean that something bad is there. Okay, this question is from Gina, and Gina says, my FSH is 12.5, estradiol 42, sperm is normal and good, AMH 1.6. My first IVF cycle, I got one good embryo that was PGS tested and normal. My doctor wants to repeat the same protocol. Gonal-F 300, Menopur 150. Is this what you would recommend? Gina, I wish I had that crystal ball, but let me tell you exactly what I would do to answer this question. Here we go. I would go through your embryo diamonds. Look at the day your embryo is frozen, the quality of the embryo, talk to your doctor about the implantation rate, and then look at the results for all the embryos. Which ones were mosaic? Which ones were abnormal? How is mosaicism being reported to you? Is normal truly normal in this lab, or are they lumping mosaics in with normals? You guys, you got to find out this stuff up front. You got to figure out, what are you opting into? Because it actually, Gina, might be that you have 2 or 3 more mosaics that you didn't even know about. And here you have more embryos than you knew about. And it would be really hard to find out later, after the fact, that you might have discarded an abnormal and it was really a low mosaic. So you got to talk to your doctor about what that means in their lab, and talk to a genetic counselor that's associated with the genetic testing company that you work with to find out more. I recommend doing post-IVF consults. Well, for all you guys, all my patients do that with me. And then certainly when there are more questions, we also schedule with a genetic counselor as well. So that's one thing that I'm thinking about for you. The other thing that I'm thinking about is if your AMH is 1.6 and you got one blast, you have to wonder, was that to be expected? What did your sparkle checklist look like throughout your cycle? What were the sizes of the follicles, right? What was the estrogen level in the time of the egg retrieval? How much trigger shot did you use? So going through the sparklemethod.com, you can go through each of those things. And I share that information with my patients at each of their visits when they come here. But not everyone will get that information, because you might not be getting an ultrasound by your fertility doctor. It might be that your ultrasound is being done by a sonographer, and then you get a call from someone else later, which is totally fine, but it's hard to maybe put all that information together. But that's another way of finding out if maybe you can tweak a few things in your protocol for your next cycle. So it sounds like if your AMH is 1.6 and you have one embryo that has normal chromosomes, that is awesome. I'm not sure how old you are, but the other thing to consider are supplements like egg quality supplements. I don't know why they help some people more than others, but I do think that taking supplements like CoQ10 can be potentially helpful for people going through IVF. Okay. Ooh, you guys, there is a page 2. Gina did give me more information. I was looking at the other page and I'm like, I don't know how old she is. She told us that she's 40. Well, one embryo is amazing and awesome. So I would say try considering the same exact protocol because you got one blast. And a lot of times you don't even get a single blast when you're over the age of 40. And I do use HGH, and I try and stay away from DHEA from someone who has a lot of eggs, but I think that everything you're on is great. Okay, page 2, here we go. This is Sindhu's question. Hi, Dr. Aimee, I just turned 35. I have a 4-year-old, which I conceived easily. I have another easy pregnancy that I had to terminate in 2019. Now I'm trying to conceive. I've been trying for 4 months now. My AMH is very low at 0.5 and my follicle count is 11 in 1 month and only 5 in another. I'm worried about these numbers. Should I go to IVF directly or keep trying naturally? So Sindhu, I am one of those people that's like, if you're over the age of 32 and you want more than one baby and doing IVF is acceptable to you, do IVF. However, this is the thing. I know you feel like your AMH is really, really low, but I have to tell you, you might be getting more than one normal embryo in a batch. So you might have something called unused embryos. This is the time to talk about how that would feel for you. You got pregnant just 2 years ago, so it may not be a bad idea to ask yourself, what would I do with unused embryos? Would I be okay with discarding, donating, or donating to another family or donating to research? And if the answer is, I would be okay with doing any of those things, or maybe having more children, then I would say IVF sounds like a great idea. This is a great time to do IVF for you. It sounds like your follicle count is going up and down, and that's really, really normal. I talk about egg counts like waves, and you're just waiting for the right wave to ride. So knowing that you had one follicle count of 11 and one of 5, you might want to see when you have another follicle count that's a little bit higher to ride that wave. I'm not sure what the analogy is, ride the wave to shore, but I'm sure I'm going to figure out that one soon enough. This next question is from Vola. Vola says, hi, Dr. Aimee. You're my biggest support in my InvoCell journey. Here we go. I'm 34 years old, husband's 39, and our InvoCell cycle did not work. My AMH is 4.2, thyroid problem, TSH of 2.4, fixed with medications. My medications were Follistim 150 for 5 days and Follistim of 75, Ganirelix, Menopur for 5 days, and I triggered with Ovidrel. I had follicles growing in the right ovary only. Why? So I have to tell you that not all follicles, let me just tell you this. When we stimulate with hormones, it's weird. Like sometimes just one ovary responds. And it's like, I wish I could, have patients take drugs like on one side and then the right side would respond, or the left side and the left side would respond, but it doesn't really work that way. It's really strange. You would think it should, but it doesn't. But sometimes it just happens that way, and I don't think there's a real reason for that. Then the next question is this. I had 6 follicles, 2 centimeter plus in size, and 4 smallers 2 days before the retrieval, and only 4 eggs were collected, and of them only 2 were mature. Why the follicles were empty? So it could possibly be, 1, that you were ovulating on the day of the egg retrieval, so you wanted to ask your doctor that. 2, there could actually be an egg quality issue going on, and that's another reason why sometimes you don't get as many mature eggs as expected. And then 3, the dose of the trigger shot may not have been enough for you. So you wrote Ovidrel 500 micrograms. So actually, I think that's actually a really good dose. That's equivalent to, I think, close to 12,000 units of HCG. So look at the timing of your trigger shot, the estrogen level at the time of the trigger, and then ask your doctor if there's anything you can do differently next time. So the next question is this. Both fertilized successfully, so she got 2 eggs with ICSI, sperm count and quality are low, but stopped developing on day 3 with high fragmentation. What could cause it? So you said the word. I know you were referring to fragmentation of your embryos, but the word is DNA fragmentation of the sperm. So an embryo, you guys, I know you know this, is an egg cell and a sperm cell together, right? So when you make an embryo and it doesn't grow, and the sperm cell that you use to make the embryo is low quality, that could be the reason. So when you have sperm DNA, for example, that's not as high quality as it could be, then you might not have good embryo progression and you might not have good embryo quality. So there's a really easy way to test it. You just do a sperm DNA fragmentation test, and there are tests that you can do in the lab, or there's tools, not tests, that you can use in the lab that might improve the sperm DNA fragmentation, like Zymot or Pixie. But I would also go through my BALLS method, ballsmethod.com, to look at all the things that you can do, like look for a varicocele, look at the testosterone level and improve it, avoid heat exposure, take supplements, and improve your lifestyle. Easy stuff. This is stuff that can help with your general health and well-being. So then the next question is, what would you do for the next cycle? So, voila, I would say, let's focus on making the sperm sparkle. I know, irritating. Every time I say sparkle, you guys are probably like, oh, that's so annoying. But seriously, that's what we need. We need to get a sperm to sparkle. We need to figure out why the count is low, why the quality is low, and what can we do to make it better. You're only 34 and your AMH is through the roof. So I'm not necessarily worried about your eggs. But at the same time, if there's a possibility that we're missing a diagnosis of PCOS and there are things that we can do to improve your egg quality, let's do that. So talk to your doctor about checking a PCOS panel, looking at your testosterone, and seeing what other supplements you might want to consider taking, like Ovasitol as an example, and CoQ10. So those are a couple things that I would do for you. The next question is, what would you do for the next cycle? So for the next cycle, what I would suggest doing is talk to your doctor about using a protocol that combines fertility pills and injections. And I'm doing this and this because 5 days of pills with overlapping injections might help. We don't necessarily want you to grow 20 eggs when you're doing InvoCell because only a certain number of eggs can actually fit in the chamber. It would be great if we could get, let's say, maybe 10 to 12 mature eggs at least to expect to be able to retrieve from you. And so not getting so many to grow from the very beginning is one strategy, and the way you can do that potentially is with a hybrid type of protocol. So talk to your doctor about that and see if they would be comfortable with it. And you might want to avoid the actual chamber. So you guys are like, what is this chamber that she's talking about? Let me actually see. I think I have one in here. Here it is. I got lots of stuff in my desk over here. So this is what an InvoCell chamber looks like. This is the vaginal chamber, okay? You can see there's that little conical tube right there. So after the retrieval, egg and sperm are placed here, and you literally have this, well, I place it in the vagina like that, and then I put this little membrane inside on top of it, and it just sits there for 3 to 5 days before I remove the chamber, and then we pop it open, and it's like Christmas Day. Literally, that's what I tell my patients. It's like Christmas Day. You're either going to get coal, unfortunately, sometimes you don't get anything, or you're going to get the best present in the world, which is a beautiful embryo. And I think what we learned in your situation is that InvoCell probably isn't the best because of the sperm side of things. So as far as any other diagnostic tests that I can suggest for you, I would recommend doing chromosome testing as well. Let's make sure we're not missing a chromosome issue for either one of you before you do another cycle. Thank you for asking those questions. This next question is from Eileen. Eileen says, hi, Dr. Aimee, I'm 40, my husband is 44. He had a vasectomy reversal January of 2019, which was successful, and we've been trying to conceive each month since then, and we finally went through IVF in December of 2020. Our results showed 8 retrieved, 7 fertilized, 3 made it to blastocyst, and 1 came back normal after genetic testing. That is great. My question is this: because of my age, should we do another round before transferring the one we have? And in your opinion, do you think we would have success with IUI? The reason I ask is because financially, it is a lot of money, but we also want to take advantage of my age. I turned 41 in August. Thank you, by the way. I love your show. I wish there were more doctors as enthusiastic as you. Hope to hear from you soon. Take care. Eileen, I'm telling you, I'm ridiculously enthusiastic. I mean, like, I walk through each door when I'm seeing a patient, and I want to make sure that I'm lifting her up. And by me lifting her up, I feel energized as well. It's contagious, I'm telling you. So thank you, Eileen, for saying that. So this is the thing. When you have a partner who's had a vasectomy reversal, there's an issue that can sometimes happen, and that is called anti-sperm antibodies. The other thing is that even though he has sperm when he ejaculates, the problem is after a vasectomy reversal, the sperm might not be that sparkly. The volume might be low, the count might be low, the motility will be low. It's great that he had plenty of sperm for you guys to go through IVF with, but it might not be enough for natural conception or IUI. So I would do a sperm test like the meetfellow.com/egg whisperer that I talked to you guys about. I have zero affiliation with anybody that I bring up. I just tell people, I like your test, give me a cool link and I'll talk about it on my show, and that's what I'm doing to make things easier for you. So that's one thing that I would consider doing. And the answer is yes. I have patients where I've helped them get one embryo, and then I'm like, look, that IVF cycle, that was a lot of money. We want to just not do that again. And then we just focus on other ways of getting pregnant. But I feel like figuring out the diagnosis just a little bit more to see if your sperm is an IUI range would be my recommendation from here first, before you decide to do IUIs or another cycle of IVF. Okay, this next question is this. This is from Karen, and Karen says, do you always recommend estrogen prior to the beginning of an IVF cycle? I'm going through my first IVF cycle in February. My doctor did not make that recommendation for me. But a friend of mine that is being seen at the same clinic as me was recommended estrogen for 2 weeks prior to starting her IVF meds. So Karen, it's kind of like, what am I trying to say? I wish I had a good analogy, but there are no two fertility patients that are alike. There are no two stories that are alike. That's why I sit and I talk to my patients and I figure out what's wrong, and then I design a protocol just for them. I don't just say, IVF, here's the recipe, and you're going on a general recipe. So there are some patients where I have them start estrogen maybe for 3 days or a week before their stim start. I have other patients where they take a shot of ganirelix at the start of their stim. I have other patients where they start their stim and they take their ganirelix later. I have other patients where I have them start birth control pills. I think of them as IVF planning pills or fertility planning pills. There's so many different ways of starting an IVF cycle, and no two patients are alike. So I'll give you an example of when I use the estrogen before stim start. I use that if there's a patient of mine who likes to ovulate super early. Like day 4, they have a 17 millimeter follicle and they're like, hello. And I'm like, no, you are ruining my cycle. Go away. So that's why a little whiff of estrogen can sometimes suppress that rush of hormones at the very beginning and can be very, very helpful. So maybe that's what is going on with your friend. But I would ask your doctor, what protocol are you using for me and why? And what do you think my IVF pyramid will look like? And you guys are like, pyramid, what is she talking about? Well, go to my article on my website, What is IVF? And you're going to see a picture called the IVF pyramid. It's like the IVF pyramid. And make sure you print that out, bring it to your doctor and be like, what will it look like for me? And I'm always talking to my patients about it. I'm talking to them about their sparkle checklist. I'm talking about what their pyramid looks like at each visit. Even if they don't know that I'm doing that, I'm doing it. This next question is from Jamie. Jamie says this, hi, Dr. Aimee. I'm 40 with an AMH of 0.59. I'm about to start my first cycle with stim starting January 23rd. I have been taking a lot of supplements in the hopes of raising my chances of getting a healthy embryo. I'm wondering if there are any supplements I should not take during stim, and here's what I'm taking right now. Here we go, you guys. Baby aspirin, PQQ, nicotinamide with pterostilbene, NAC, myoinositol, arginine L-carnitine, acetyl L-carnitine, ubiquinol, vitamin D3 with K2, omega-3, alpha-lipoic acid, DHEA, prenatals, magnesium, melatonin, additional calcium, vitamin C, B12, folic acid, and iron. Whew! Holy smokes, that's a lot of supplements. I'll tell you what I would say if you were a patient of mine. I would say, stop it. I would say, cut out the baby aspirin. All I really need you to take is prenatal, vitamin D, fish oil, CoQ10, NAD, pterostilbene. That's it. 6 things. That's a lot of pills to take every day. However, if there's a reason why you need to take some of those things and I don't know about it, please don't listen to me. But I just worry that people are just taking too many things. That's a lot of pills to swallow. That's a lot. So I would just focus on the basics, and I know that's still a long list of stuff, but that's what I would tell my patients, and that's what I tell them too. Okay, this next question is from Jumana, and Jumana says, I am 44 years old preparing for my embryo transfer in March with an egg donor. However, this month for the first time, I didn't get my period, and I'm on day 33. Is that normal? I've taken several pregnancy tests, and they're all negative. I've started spotting day 19, 20. I've never had a late period beyond 30 days. I would appreciate your feedback. So Jumana, this is a thing that totally happens all the time. It starts with a P and it's called perimenopause, and this is what happens. Your brain sends a signal to your ovary and says, wake up, and it does that with a hormone called FSH, and guess what that does? That creates a cyst. Super annoying because guess what? Cysts secrete estrogen. They're almost never cancerous, and when your cyst secretes estrogen, it prevents your period from coming. And then you're waiting for it, and you're waiting for it, and you're waiting for it, and then you're messaging me through Ask the Egg Whisperer, and you're like, what the heck? So, Jumana, if you called my office and said, hey, Dr. Aimee, I'm a patient of yours, and this is happening to me, I said, Jumana, don't sweat it, come on in. I'm going to see you. I'm going to do a cyst check and a level check. Basically, I'm going to look at your ovaries and tell you if there's a cyst. I'm going to check your hormone levels and see what the heck is going on. So either your ovaries are taking a break and relaxing because they know they don't have to work because you have an egg donor all picked out, or there's a cyst that's just trying to get in the way. So it's probably one of two things and nothing to worry about. This next question is from Amanda. Amanda says, hi, Dr. Aimee. Thank you for sharing all your knowledge. My question is about CoQ10. I have read, let me see, that this is something that's highly recommended to take. However, I can't seem to find information on whether or not it's safe to take for someone who has a history of blood clots. I'm 36 years old, no children, 2 miscarriages with diminished ovarian reserve. At 24, I had a pulmonary embolism, and they determined it was likely caused by birth control. Last year, my doctor said to take blood thinners should I get pregnant again. I'm currently in my first round of IUIs. My partner has less than ideal morphology. I don't know if I should be taking CoQ10 or not because there's some information suggesting that it could decrease the effectiveness of blood thinners. What's your advice? Thank you so much, Amanda. Okay, Amanda, I would recommend seeing a hematologist and getting a workup for why you had a pulmonary embolism. You might have a genetic predisposition to blood clots, and it's important to find out what that is because guess what? You can also pass that on to your children. This is the best time to find that out, especially before a pregnancy, because if you stop your blood thinner too early in pregnancy, it might be too early. And if you knew what the actual diagnosis was, then you might want to continue your blood thinners even 3 months postpartum. So I wouldn't just guess. I would test and make sure you're ruling out factor V Leiden, prothrombin gene mutation, antiphospholipid antibody syndrome, especially since you've had 2 miscarriages. And the other thing, I don't want to be rude, but you know what I'm thinking. What is your diagnosis? And you shared with me decreased ovarian reserve and low morphology. Will IUI solve that? And the answer is it may not. So remember to talk to your doctor about what you can do to improve your chances of getting pregnant naturally, because that's my style. I always tell patients, look, I want you to get pregnant without my help. And they look at me like, what? You don't want to do IVF for me? I'm like, no, I mean, I do because IVF will hopefully solve this problem. But if we can think like this, then all the things that we can do that are in our control before our cycle will give us the best chance for pregnancy. So CoQ10, if you just Google foods that give me CoQ10, and you're going to see a list. I think spinach is one of them. That doesn't cause you to have less effectiveness that I know of with a blood thinner. So my answer to you is I would not have any concern about taking CoQ10, pterostilbene, NAD, your prenatal with a history of blood clot. However, I would be concerned that we're not doing a treatment to help solve your problem. So I don't want you to take your youth for granted. You're a young woman. You're only 36, and I still think that you probably have a good chance of pregnancy with IVF. Okay, this next question comes from Anna. And Anna says this, I'm reading conflicting information about CBD for fertility. I've been using CBD oil that does not contain THC to help me sleep. I'm also curious about the anti-inflammatory properties. I've had labs done many times and my CRP is always high. My PCP believes it's related to Hashimoto's. My TSH, T3, T4 are normal, but my thyroid antibodies are always quite high. I'm planning to start IVF and wondering if this chronic inflammation will cause issues, and if so, what I can do that might help. So Anna, this is the deal. So CBD can actually bind to receptors in the lining of the uterus, theoretically, that can block implantation. They can also potentially affect embryo transfer down the fallopian tube. So I tell my patients, no THC, no CBD, and I'm sorry about that. I talk about other coping strategies that you can use to help with the symptoms that you're using the CBD for, like sleep. There are other things that you can use like melatonin. You can even get a melatonin pill, even a patch that lasts all night. So if you're having a really hard time with waking up in the middle of the night, maybe a patch is something that you can consider using. A lot of people, when I bring up a melatonin patch, they've never even heard about it. But like you can get anything from Amazon, you can also get a melatonin patch from there too. As far as your goal of reducing inflammation, I would look at your lifestyle. I would look at everything from head to toe, from meditating to breath work, to your diet. I'm just pointing to the stomach because it seemed like something that made sense. Look and follow an anti-inflammatory, maybe even a plant-based diet Work with a functional medicine doctor as well. Talk to your fertility doc. I have my go-to functional medicine doctor. So talk to your fertility doctor and see who their functional medicine doctor go-to partner is as well. Because when a patient asks me these questions, I'm like, I'm the fertility expert and I'm going to have someone way smarter about that kind of stuff work with you next. So we work together in tandem to make everything as fertile as possible for our patients. Okay, this next question is from Ilana. Ilana says, is there a difference among different HGH brands? I thought because they were all somatotropin that were therefore interchangeable. In my last IVF cycle, I used Humatrope and then Cyzin. But is there something about their formulations that makes one preferable? Is switching between brands mid-cycle okay or not advised? I often see people mention Omnitrope in connection with infertility treatment. Is that due to something particular about Omnitrope formulation, or is it just because it's the most widely available kind? Ilana, you're right. It's just because it's the most widely available kind. And wildly, wildly available. That might be my new word of the day. Everything is wildly available. It's widely available and it's a lot cheaper. So Cyzin is the brand name, and a lot of pharmacies will, if you just cost compare the two, Cyzin will be a lot more expensive. So Omnitrope is generic, and so the price point is lower. It's still ridiculously expensive. It's wildly expensive, and it can be cost prohibitive for people to use. But compared to Cyzin and other brand names, it's relatively cheaper. Okay, this next question comes from Asal. Asal says, Dr. Aimee, first and foremost, I want to say you are an angel. Well, thank you. I'm going to call my mother and tell her that because I just got in a big fight with her. I don't think she thinks I'm an angel right now. I'm 33 and a half. My AMH is 1.1, FSH is 5 on day 3, LH is 3.3, testosterone is 0.39, estradiol 34, DHEA 520. Progesterone 0.19, prolactin 16, TSH 2.4, and here's what I used. Letrozole 5 milligrams per day for 5 days, days 3 through 7. I had 2 follicles, 16 to 17 millimeters on day 9 of the cycle and thickness of around 6 millimeters. I did not conceive that month. Is this normal? What is wrong with me? How many cycles do you recommend of letrozole? So Asal, there's nothing wrong with you. You're human. This is called human reproduction, and it is so hard to get pregnant as a human. You are not alone. Your hormone levels tell me that everything is going to be okay. However, when I'm looking at things from my standpoint, I'm wondering, did we maximize your chances and optimize them in this Femera IUI cycle? Let me tell you what I do. I like to trigger when the follicles are between 20 to 22 millimeters. I like to make sure that the lining is nice and plush, like my fuzzy socks at home. I can't wait to get home and put my feet in my fuzzy socks tonight, apparently. So if I have a patient who's coming in, I'm going to trigger her, I need to make sure that I can go to sleep at night and say, I did a good job. I'm timing this just right. And I see patients 7 days a week, like literally. Patients are like, no, it's Sunday. Are you open? I'm like, uh-huh. But not everyone is. And I totally get that. I totally get that there are things that we have to do when we're fertility patients that might not be as optimal because of a schedule, like the day of the week. And I've seen things where people are triggered day 6, when their follicles are 16 millimeters and their lining's not quite there because of somebody else's schedule. So that's something to be aware of. There's probably nothing wrong with you, but I would have waited maybe a couple of days before triggering you to get the eggs just a little bit juicier and the lining just a little bit plusher before you did your IUI. So I would say consider doing that. But since you're over the age of 32 and it sounds like you don't have a baby yet at home, I would strongly suggest you either freeze eggs, freeze embryos, or both. Remember, it's always nice to have embryos at nice. Embryos on ice, especially if you're over the age of 32 and you want 2 kids and you don't have them already. So if you came to me and you were a 33-year-old single woman, I would say let's freeze 2 to 3 cycles of eggs so you have a chance to have at least 2 babies at a 50% pregnancy rate. That's kind of how I like to counsel people, so you never look back and say, why didn't I freeze more? So now that you're 33 and a half, I would say strongly suggest using technology to help you with that. The next question is this. This is about my husband. Can we conceive naturally with his sperm characteristics? Volume 4.2, low viscosity, total sperm count 144 million per milliliter, rapid linear progression 20, slow linear progression 45, normal forms 95%. Okay, so his sperm is just slightly on the slower side, and the shape of the sperm is slightly on the lower side. So when I tell people this, you never tell sperm anything just by one peek at them, because it could just not have been the best day. So just like I never just go by one snapshot of the FSH estradiol levels, for example, when people say, I got my tushy checked and everything was great, and I'm like, well, you got to just track and trend those levels, because it could be that you just caught your FSH when it was down, and really it's going up and down and fluctuating, and I just don't want to assume something that's there, like not there if it is. So same with sperm. So let's just repeat another semen analysis and see where we're at. And then think about all the things that I talk about to make the sperm sparkle, right? So avoid heat, exercise most days of the week, decrease stress, all the things that can help us have a healthier lifestyle will help the sperm too. And then consider adding IUI, if you haven't already, to your next fertility pill or letrozole cycle. So I hope all these suggestions are helping you. Remember that I'm only human. There's nothing wrong with you. And I would say focus on the positives. You're young, you have a good AMH at 1.1, and the sperm is sparkling, but let's try and see if we can get it sparkled just a little bit more soon. Okay, this next question is from Stephanie. Stephanie says, hi, Dr. Aimee, I'm heading into round 3 of IVF this year. I'm 27 years old. With unexplained infertility, likely poor egg quality. My husband's side of things is perfect. In our previous round, we had 11 eggs, 8 mature, 1 fertilized normally, which ended up progressing to day 6, but did not develop an inner cell mass, so we could not transfer it. My doctor is wanting to change to a menopause-only cycle, adding in calcium activation, doing ICSI this time, and time-lapse imaging of the embryos. Do you think these protocol changes may help fertilization rates? I take all your supplements you recommend. Are there any other strategies you would recommend too? Thank you. Stephanie, the first thing I would do is also consider taking HGH and do it now. And I know this sounds a little frou-frou. I don't know what the word frou-frou even means, but it sounds appropriate right now. Is go see an acupuncturist that can use low-level laser therapy or the red light. Little belt you put on your tummy, you can use it twice a week and see if that will help. As far as the strategy of using Menopure only, I gotta tell you, that's all I do. Most of my patients are using 225 to 300 units of Menopure only with just a whiff of gonal F or FSH hormone on top. I actually find that that gives me better quality embryos than flipping things the other way, using more gonal and less Menopure. I've always done it. Not always, maybe since like 2010. So it feels like always done it. As far as the sperm, even though his sperm is great, let's also consider adding a Zymot fertility chip, run it through there, a more stringent way of picking out the sperm before you putting it into the egg, or consider adding Pixie. Whatever your clinic can do to make the sperm even better, let's choose that as well. I do like the idea of calcium activation in a case like yours. However, I don't find it as helpful in cases where the egg quality is poor, but your fertilization rate is what makes me think that it could be helpful in your situation. So I would absolutely add calcium activation in a case like yours, and I hope that you're going to have the fertilization that you need, the blast formation rate that you so deserve, and sparkling embryos so that you can transfer in the very, very near future. The other thing, I feel like there was one more thing that I would consider for you. I talked about HGH, all the supplements, calcium activation, adding a little something, something. The other thing to consider doing is, no, I think that's it. I don't know about your trigger shot protocol, but maybe adding Lupron with the HCG and maybe a little bit of FSH hormone might help with egg quality, because it sounds like we have an embryo quality situation that might be due to egg quality. And so those little changes could also help. This next question is from Kirti, and Kirti says, hi, Dr. Aimee, thanks for answering my question. You're welcome, Kirti. Me and my husband are 33 years old. We've been trying for 3 years with one successful IUI resulting in a 9-week loss, and then 3 IUIs afterwards that didn't work. We did an Ivf cycle in August of 2020, which resulted in 4 embryos out of 12 eggs, and 2 day 3 embryos were transferred and did not result in a pregnancy. We changed doctors and did another IVF and got 6 blastocysts and 3 PGS tested normal embryos. We transferred 1 and it didn't implant. I'm just going to take a little drink of my coffee here. My lining was 7.5 millimeters in trilaminar, and progesterone and estrogen levels were 50 and 500. I don't have any underlying issues. My AMH is 2.6. What can we do to have a successful transfer? What could be done? So here's the thing. I'm very picky about linings. Super, super picky. My patients all know it. They know how picky I am. Calling a patient and telling her your transfer doesn't work sucks. And that's why I have to remind patients when I'm super picky. I'm like, listen, I know I'm giving you bad news. I'm not quite there yet with confirming that we're ready to transfer because your lining isn't thick enough. But let me tell you, I would much rather be telling you that than telling you, I'm really sorry, Kirti, the transfer didn't work. We can handle, we're not quite ready to transfer. I personally, because I'm so personally involved with each of my patients' stories, their cycles, and their success, that I have to make sure that I'm getting the lining even thicker. My goal is over 8 millimeters for all of my patients. And then because of everything you've been through and you have a couple embryos left, I would strongly suggest, I don't know how many kids you guys want. I know it's hard to think about doing this. Do another cycle now. Get more embryos. Because if, let's say, you transfer now and you guys are successful, and then what will happen in the future, you just don't know. And because you worked so hard for these embryos when you were 33, it would make perfect sense to do another cycle now with your 33-year-old eggs. And let's talk about why we're here. Why? Is it egg quality? Is it embryo quality? Is it a little bit of both? Is there a sperm situation? So I would also look back and kind of talk to your doctor about what is my diagnosis? What have you ruled out? And why did I have the miscarriage? And they're going to look at you like, wait, what? And they'll be like, well, it's unexplained. I'm just kidding. Don't let them say that. Say, what are the possible explanations in my case? And so that's why I've come up with these little simple methods, right? So the angel method, we want to know why you had that miscarriage, okay? Is it an anatomic issue in your uterus? Are we missing something like an antiphospholipid antibody syndrome? Get tested for that. When I talk about anatomic issue in the uterus, I'm talking about, for example, a uterine septum. And then just go down that list and make sure you've looked at all of those things. And then we want to also know, what is it, like, why are we even doing IVF, right? Could it be silent endometriosis? And could that be somehow connected to the miscarriage? Let that pregnancy teach you the lessons that you need to learn before you do another transfer. And in a case like yours, I would also consider doing 2 tests, the ERA test and the Receptiva DX test. And I would run you through a dummy cycle. And we would take all the meds as if we're going to transfer, but we don't. And I make sure that I get your lining over 8 millimeters before I do the biopsy. Then I take a sample of solids and send it to the 2 companies and learn more. And we use that information to guide us and tell us what to do next. However, I would strongly suggest that you do IVF first. Before you do any more testing, it will just feel way more comfortable to go into your next transfer, knowing that you have more embryos for your future because you're so young at 33 and you've worked so hard for these embryos. And I want to see you have more than 1 baby if that's also what you want for yourself. Okay, guys, this is my last question for today. This is from Olivia. And Olivia is saying, my husband and I are 29 years old and have been trying for 14 months and have recently been diagnosed with unexplained infertility by my fertility doctor. At this point, what are the chances that we could conceive naturally? Do couples with unexplained infertility have success with IUI and IVF? How do you recommend we proceed from here? So Olivia, I would ask your doctor, what are the possible explanations in my case and what have you ruled out for me? Have you ruled out a tubal issue, a uterine polyp, adenomyosis, endometriosis, a sperm issue? Is the sperm DNA good? How are my hormones, FSH, estradiol, AMH, my testosterone, my TSH, my prolactin? Have you looked at all our genetic screens, chromosome analysis, and carrier screen, for example? I know I just rattled off a whole bunch of stuff, but that's the checklist. I mean, basically, before you can even get to unexplained, we got to figure that stuff out. And if still everything is literally normal, like the sperm morphology is like 12%, the DNA fragmentation is great, the FSH is good, the uterus looks great, then you have to wonder, could there be some sort of fertilization issue that you can't diagnose with all the tests that I just referred to? Could it be an egg quality issue? Sometimes you can still have an egg quality issue despite having all labs being totally perfect and a young age. But I have a feeling that if you really went through each of the things that I just shared with you, you would be able to get to some sort of diagnosis that could help you figure out what to do next. So because you're 29 and you've been trying for over a year, I would say it would make perfect sense to freeze eggs, embryos, or both. But remember what I said at the beginning of the show, when you're making embryos and you're young and you might have a lot of unused embryos, it's really important to talk through what that means to you. So I know when you don't have any embryos at all and you don't have children, you can't really think that far. But I know I'm going to be anti-Aimee right now and say, please think that far and think through those things before you make a decision to make precious embryos. Consider doing half eggs, half embryos, depending on how many eggs you get. So that's my advice for you. Okay, guys, Thank you for joining Ask the Egg Whisperer today. I am now going to go to the live chatted questions. I have some IVF classes and egg freezing classes coming up, so go to the Egg Whisperer School to sign up. And it's a really fun way to hear more of my jokes. And I'll be going to a joke writing school very, very soon. I'm pretty funny, you guys, on Fridays. Maybe not so much on Wednesdays. Let's kind of go through the questions here. Someone's saying, curious to know if Tylenol is safe during pregnancy, and if so, how much? And the answer is, if you're needing to take Tylenol, please talk to your doctor about why, to see what else they can do to help you. I don't want to miss a diagnosis, like let's say COVID and your fevers are high and you're having problems coughing. You know what I mean? But in general, Tylenol is considered safe in pregnancy. Next question is, how soon after IUI can you get a positive pregnancy test? My appointment isn't for 2.5 weeks. So I typically tell my patients to check for their IUI pregnancy 12 days after their IUI. That's what I tell them. Next question is heart rate at 6 weeks, 3 days. So sometimes you can see a heart rate of even 90 beats per minute in an embryo at 6 weeks, 3 days, and that can be perfectly normal. The average is around 120. Next question is, I'm 34 years old with DOR, probably due to endometriosis. My husband's semen analysis was normal, but just got DNA fragmentation, and DFI is slightly abnormal at 31. Would you recommend just adding more supplements like C, E, zinc, or, let's see a urologist to check for a varicocele? I would do it all. I would get them on supplements. I would check for a varicocele. I would do hormone testing, genetic screening, and then find out what the diagnosis is, repeat the sperm DNA fragmentation test, and then talk to the doctor, your fertility doctor, about what they can do in the lab to make the sperm DNA fragmentation go down. If you guys get pregnant naturally or with IUI, remember what I say, it's always nice to have sperm on ice. So I have a patient right now, and I told her that they got pregnant naturally, and she remembered me saying that because they had low sperm quality, and she's like, aha, Aimee said that. So that when we're ready for baby number 2, we don't have to say, why don't we have sperm frozen for us? It'll be just sitting there in the bank. Next question is, I have a day 6 PGTA normal embryo from my first round. Should I be concerned with my odds of successful transfer? Also, my clinic will not do assisted hatching on a PGTA tested embryo. Is that normal? So the answer is a day 6 beautiful blast that has normal chromosomes, thumbs up. I'm not worried about it. Every lab's a little bit different. Some labs have varying pregnancy rates between day 5 and day 6. And when I say varying, I mean much lower. But most labs that I work with, they're about the same, maybe 1 to 2% chance lower. So I don't worry about day 6 embryos at all in my hands. And to answer your question about assisted hatching, I have to tell you something. Your embryo's already hatched. That's how they do genetic testing of the embryo. They have to hatch the embryo on day 3 to do the biopsy, to send it off to the genetic testing company. So I wouldn't worry about them saying they don't do a hatching. It's because they already did it. However, if they're saying that they've never done assisted hatching on your embryo, then you need to talk to them about, how do you guys do the embryo biopsy? Good question to ask. I want to know the answer to that. Someone's asking, any supplements you should stop doing during the 2-week wait? Are they all safe to continue into pregnancy? So I would say if you're taking DHEA, stop it. I typically don't tell my patients to continue Terostilbene and NAD. I do have some of my patients continue CoQ10, and I certainly have many patients, especially my PCOS patients, continue Ovasitol even in pregnancy. Next question is, if you have MTHFR Pi1 gene heterozygosity and a subchorionic hematoma, would you stop heparin, or is it okay to do every other day? No bleeding from the subchorionic hematoma. It depends on the size of the subchorionic hematoma. If the hematoma is really big, then I would say stop it. If the subchorionic hematoma is super small, I would say continue it. And at any sign of bleeding, stop it immediately. Next question is, hi, Dr. Aimee, just want to say thank you. I wrote in about a lack of a trilaminar layers, and you suggested estrogen patches. And this cycle, I had a beautiful trilaminar lining. Yay! That's really awesome. You're giving me chills. That's really exciting. Okay, next question is this. Do you repeat the AMH before the IVF cycle? My AMH was 1.67 a year ago. Recent AFC is 24 things. And yeah, I do like to repeat it. I don't require it at all, but it's just fun for me to see what where the level is at. I just like to have it as a data point just to show my patients. So we're like, yes, we're on the right track. The fact that your follicle count is over 20 just tells me that your AMH is going to be fabulous as well. Next question is this. Is it worrying for a baby measuring behind and slow growing? 5 weeks, 6 days, measured 5 weeks, 5, 6 weeks, 3 days, measured 6 weeks, 107 heart rate. So I would say I'm not too worried. However, if it's a Wednesday and you're seeing me today and we're seeing this, I'm going to say, you know what? What are you doing this weekend? Can you come in on Saturday? I'd love to look at your pregnancy again, because I know if it were me, I would scan myself every single day watching that baby grow. And I know people don't have access to technology the way a fertility doctor does for herself. So that's why I would tell you to come on in a few days. Let's just take a look again so we're not worried. Next question is from Rebecca. Hi, Dr. Aimee. I had one failed IVF cycle, 31 years old, AMH of 0.6 and endometriosis. We got 7 eggs, 6 mature, and 1 fertilized, and it did not make it to blastocyst. What should I do from here? So what I would say is, why is your diagnosis endometriosis? And what I mean by that, not to sound like a smart aleck, is how do we know? Do you have large endometriomas on your ovaries? We know that endometriosis can affect egg quality. It really, really can. You get less mature eggs, less good quality eggs as well. So talk to your doctor about whether you would be a candidate for having surgery for endometriosis before your next cycle. Talk to them about different strategies for IVF protocols that might suit you better. Talk about HGH, all the supplements I talk about when it comes to improving egg quality, and even talk to your doctor about a supplement called NAC, N-acetylcysteine, that can also help with endometriosis. Next question is, third egg retrieval, my follicle count was 8, estrogen was 55 on day 4, gonal was increased from 300 to 325, and menopur from 75 to 150. Day 5 estrogen was 89, with 4 follicles, largest is 10. Is this okay? I'm going back tomorrow. Let me tell you. Sometimes your ovaries tell you a story, and they're telling you, leave me alone. So I would listen to what your ovaries are saying. So if you're a patient of mine and you're not on Femara, because I put a lot of patients on Femara in their IVF cycles, and those estrogen levels are perfectly normal. But if you're not on Femara, then I would say, you know what, your ovaries are telling me to leave you alone. Let's just stop what we're doing right now. Your ovaries are going to come back and join the party. But it doesn't seem like this is the best IVF cycle. I don't do cycles just to do them. I don't do them for closer just to do it and get it done. I do it because I actually really, really want them to work, like really, 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 really badly. And so the story and the description of the cycle that you're giving me, the sparkle checklist, is telling me maybe we should not keep going. So the K and the A of the sparkle is, are you happy? And the K is keep going. And I feel like I would say, I'm not as happy as I would like to be. And I would probably suggest not to keep going. Save your money, save your meds, and consider waiting another cycle. Let's see here. My husband, it looks like, he does sperm cycling advice for an egg retrieval. We'll do ICSI. Oh, I see what you're saying. Ejaculation. So I recommend ejaculating every 2 to 3 days during an egg retrieval cycle or IVF cycle, having your husband or a partner ejaculate the day before the trigger shot. That's what I tell my patients to do. Next question is 43 too old to do IUI? And the answer is no. Next question is, I'm freshly 36, AMH is 0.85, just had my retrieval and got 7 eggs, 5 mature, 5 fertilized, and ended up with 3 blasts, 4A, 4AA, 4BB, transfer to 4A on day 5. Chances of it working, I'm 4 days post-transfer and anxious. So I would say at 36, if the embryo is not genetically tested, each embryo has about, let's say, a 30% chance of being genetically normal. So I would say, assuming it's normal, given that quality, you have probably a 75% chance or better of it working. We just don't know if it's normal or not. Oh my God, you guys, so many questions here. I don't know what to do. I'm so overwhelmed. I'm just kidding, I'm not overwhelmed. I love answering your questions. But I think I'm going to end tonight's show because I have a lot of patients to call back, review labs, do trigger shot instructions, and that's my main job. Clearly, I should keep my day job because comedy just, you know, I need a comedy writer to make this more fun. But I love answering your questions, and thank you guys for being here tonight, and I look forward to seeing you again tomorrow. Have a great night, and I'm sorry I didn't get to all your chatted questions tonight, and I hope to be able to have more time tomorrow. I love you guys, and I'll see you soon. Bye-bye.